Morning. Do we have a court reporter this morning? Uh, Kristen, are you here? Is my audio working? Okay. All right, I got some
Yeah.
response. That's a good start. All right, is there a court reporter, or Kristen, do you know who our court reporter is? All right, I'm gonna give this a minute just so I can call and see where the court reporter is. Okay, Sierra, are you here?
Yes, I am.
Okay, great. And then Mr. Costa, are you here? Apparently, the meeting for today was noticed for two different times. In one place 9 a.m. and one other place 9:30. So I'm just checking if Mr. Costa is here, and if he's not here, we'll have to start at 9:30. If he is here, we can just get going. Michael, are you here? Okay. All right, since he's not here, it's noticed in two different places. We'll start at 9:30 and someone on our end, could you put up a sign just for the website or for the meeting link that it'll start at 9:30? Thank you. Hey, good morning. Mr. Costa, are you here?
I am, Mr. Chairman.
Great, nice to see you. Sierra, are you here?
Yes, I am.
Great, okay, we can go on the record, please.
We're on the record.
All right, good morning. Today is August 12th. This morning we have Gifford's presentation, and then Mount Scottney at 12:15 approximately, and then Springfield Hospital. I will have Julia Korelman, our counsel, swear in Mr. Costa and his team. Mr. Costa, after Ms. Korelman reads the oath, please have each of your witnesses affirm the oath and state their name, and we'll turn it to you for a 20 to 30-minute presentation. Thank you.
All right, thank you very much, Chair Foster. So I will jump in and read the oath. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalty of perjury?
I do. Michael Acosta, President and CEO, Gifford Healthcare. I invite my team to do the same.
Hofer, Chief Financial Officer, Gifford Healthcare.
Megan McCormick.
I do. Megan McCormick, Vice President of Clinical Services.
Sarah Simeone.
I do. Sarah Simeone, Vice President of Nursing, Quality, and Patient Safety.
Bill King.
I do. William King, Interim Director of Finance.
Heather Impey.
I do. Heather Empey, Executive Director, Manning Nursing Home.
Those are all the members of the Gifford team that I anticipate speaking today.
Great. And if possible, if each of the Gifford team members could turn on their cameras, that'll be helpful as well. We'll turn to you, Mr. Costa. Thanks for being here.
Thank you very much. I'm going to share my slides. This is always the most nerve-wracking moment of the hearing for CEOs, I'm sure. Right. And can everybody see them?
You succeeded.
Thank you so much, Mr. Chairman. So I just want to start by thanking the members of the Green Mountain Care Board, their staff, the healthcare advocate, and everybody involved in this process. It's a genuine privilege to be here as President and CEO of Gifford. I feel like we're back here again this year with you as a partner. Right now, it seems like there is strong alignment among the state of Vermont, the Green Mountain Care Board, the Agency of Human Services, and Vermont's healthcare system to try to create a more affordable, accessible healthcare system. And last year, we came in with one simple guidepost. We're going to share with you everything that's going on with Gifford, the good and the bad, and tell you what we plan to do about it and where we're heading in the future. That journey has continued over the last year. We're very proud of the story we have to tell. And we come here to tell it in a spirit of partnership. Now, you are our regulator. And so in this business, you are our accountability partner to push at us to make sure that, Vermonters are getting what they need when they need it and at the right price. I also want to acknowledge and say thank you to your staff. Well, our senior leadership team has been pretty stable over the last year, except for some really excellent additions. We did lose our CFO in the middle of this process. She was out for a month on personal leave and then accepted another job that was too good to say no to. And so we changed CFOs on July 24th, and we have a new CFO, Chris Fraunhofer, joined us on July 27th. And your staff has been an excellent partner as we try to navigate that during the budget process. So as we get into our story, we're going to talk a little bit about who we are. We're going to talk a little bit about what we want with our proposal within the budget process, and then a little bit about how we plan to do our work and why you should trust us to do it. And then most importantly, answer your questions and that of your staff and the healthcare advocate. So Gifford is an unusual corporate entity. As you know, we are a miniature independent healthcare system. We are not just a hospital. We are Gifford Healthcare, a federally qualified health center, Gifford Medical Center, a 25-bed critical access hospital, and Gifford Retirement Community. And we try to care for people through all stages of life here in the geographic center of Vermont, wedged between Dartmouth and UVM. And that structure has taken shape over the last 123 years for one simple reason. It's what the people in our communities needed to be cared for, as we try to offer local care right now for people from birth through palliative care and end-of-life services. Just a little bit more detail about who we are and what we do. Beyond being an independent health system, we're also Orange County's largest employer. We are a federally qualified health center whose visits are growing. We have over 50,000 visits this past year, and that serves 14,781 unique patients, both at our sites, which are in Sharon, Chelsea, Randolph, Bethel, Rochester, and Berlin, and in schools. Our main campus is here in Randolph, offering a variety of services, including our birthing center, which we're enormously proud of. And we were especially pleased to tell our staff this year that we are Vermont's only 5-star hospital as rated by CMS. It's really a tribute to the hard work that they do every single day. As we take care of people through all stages of life, we of course have our nursing home. The Menning Nursing Home is beautiful. It's right off exit 4 on 89. It is a 30-bed skilled nursing and long-term care facility. And we have an adult daycare, which those are definitely under strain in Vermont, and we're very proud of ours. They provide social interaction, medication management, and meals to older adults, and then importantly provides respite services for our caregivers. And then we, of course, have a 49-unit independent living campus, Strode. Now, we came to you last year and said, it's a new day at Gifford, and that we had been through some enormous struggles, perhaps like some other hospitals and health systems in Vermont. But we owed you the truth about where we were and the fact that it was going to be a multi-year turnaround. We're here to tell the next chapter of that story. So last year, FY26, we felt like we were talking to you about a turnaround budget, that we needed to make progress, but we were still going to be in a lost position. We really needed to reestablish credibility with our own internal team, reestablish credibility with our financiers, and we need to reestablish credibility with all of you in the state of Vermont, and make sure we do that by having our budgets more closely match operations. The budget we come to you with today, we're referring to as the efficiency budget. How do we return to a positive operating margin? How do we focus on efficiencies? And how do we determine what normal operating conditions are? And here's what I mean about that. And we've talked a lot about it as a senior management team and with our board of directors that has been very active during this turnaround. When we talk about regionalization and the future of healthcare in Vermont, it'd be helpful to know what steady state operations look like at Gifford. What are the right essential services? What is the right level of productivity? What is the right level of performance? And we think this budget brings us much closer to that. And that conversation is not just with the senior leadership team and our board of directors. Everything that we're about to talk to you about today has already been announced to our staff in all staff meetings and all team communications to our 500 employees over the course of the last few weeks. We have confidence that these are the right moves, and we believe in a time of change, we need to be absolutely radically transparent with our workforce. And then our hope is to bring you a transformation budget in FY28. We want to say we're doing a new strategic planning process. The board is very engaged in that. The plan is to have it adopted in time for the next fiscal year and use that to make sure that we can be a key leader and driver in the transformation work that's currently ongoing in Vermont. In this arc, when I informally talk to my colleagues about this 3-year turnaround, I say to them, last year was about getting back in the game. This year is about playing to win. How do we become the most efficient version of ourselves to make sure that we're sustainable and affordable and accessible for our communities and Vermonters? So we try now to be guided by some very simple goals. And so the budget before you is designed to meet 3 core business goals. And frankly, these just feel like the table stakes to get in that game. One is to meet your guidance. Very important to us to try to come in with a budget that meets your guidance to show credibility and determination about the affordability goals and healthcare reform goals that the entire state is focused upon. And if we're able to do that and get our budget approved as is, we think that'll provide us as a leadership team some business certainty. And it also gives us credibility with our bankers and bondholders that we know what we're doing and that we have a path forward. 2, we have to return to profitability. The current budget represents a 1.4% positive margin for Gifford Medical Center, the hospital, but also a 1% margin for the organization overall. And while we make this distinction between the medical center and everything else in this budget presentation, as we put in our budget narrative, we really think of it as one company. And if we're able to return to profitability, we can make necessary investments in our team, in our facilities, in our communities, and our patients. And then we must remain compliant with our bank covenants. When I arrived at Gifford in 2024, we were out of compliance with our bank covenants, and our bondholders have been excellent partners with us in trying to navigate that situation and get on track. And so currently we have two major bank covenants, which we've submitted to your staff at their request. One is a quarterly EBITDA requirement that rises over time, and the other is a days cash on hand mark. As we come before you, we believe we have met that guidance, although we do want to talk a little bit about expense growth. We have reduced overall commercial rate request by -1% per guidance, and we've also reduced the overall commercial revenue budgeted to the organization by -1% for FY26. Now, on the expense growth, we are currently bringing you a budget where Gifford Medical Center hospital expenses rise about 3%. But part of that is because of a cost allocation change that occurred in FY26. We believe that if you compare our cost allocation from last year to next year on an apples to apples basis, expenses at the hospital only rising 0.5%. And then overall, Gifford Healthcare as an entire corporation, our expenses are increasing 2.1% overall for FY27, which is within the board's guidance. The reason why that cost allocation occurred is twofold. One, Medicare cost settlement. And two, we're just trying to simply improve every aspect of our business. And so in FY25, this senior leadership team as it came together worked to improve Gifford. And part of the way in which we improved it is that we made it much more productive. So for example, our inpatient census went from about 8.7 up to 12 and 13. While doing that, costs stayed relatively the same. And so at that point during the Medicare cost settlement, there was the potential for a very large payable to Medicare. And so we asked our cost settlement preparer and others whether they'd be open to us reallocating costs. At the time, what we learned was Gifford was using bespoke time surveys to figure out how to allocate expenses. And that didn't seem like the best or most methodologically defensible solution. And so at the beginning of this fiscal year, during the Medicare cost settlement process, we redid our cost allocation category by category. So for example, in human resources, we allocate people's time based on how many employees are in each part of our company. For marketing and communications, we do it by gross revenue. And so we went category by category. And what happened then was that almost $2 million of cost was redistributed, and it was mostly reallocated from the FQHC to the hospital and nursing home. The two benefits of that were to reduce the Medicare payable, thereby keeping precious federal dollars in Vermont. But also, we just think we have a better way of doing this to better understand our cost structure. And so that $1.45 million cost increase to Gifford Medical Center those are not new expenses into the system. They are not costing Vermonters more. They're simply being allocated from one part of our corporation to the other. Now, before we get into the nuts and bolts of our budget, we do want to talk about affordability. And so, our view within the FY27 budget is that efficiency, pricing, and financial aid are all part of promoting affordability. Perhaps the most important sentence in this entire presentation is that we agree that Vermonters pay too much for healthcare. I think we're all focused on that. Now it's about what can we do about it. And so we think this is going to be a long-term effort to work on affordability in the system. And we're engaged in three major affordability strategies. One, we just need to do our work better. We need to promote efficiency and partner with others in the system to keep costs down over the short term and the long term. We 100% need to review pricing. We'll get into that more in a second. And then we also need to strengthen our financial assistance policies, and not just on paper, but in the real world as well, making sure that our patients understand the cost of services, making sure they understand what is available to them as far as financial aid and charity care, and then actually doing something to help them with that. So in the future, if we all do these things right, we think that there's a best case scenario where we can work with insurers, public and private, and say we offer services at the best price and with the best access, that we can offer local care right now, particularly for services where people may be waiting a long time at other places in the system. So we have done a lot of soul searching based on the good discussion that this board has convened regarding critical access hospital pricing and the effect of Medicare reimbursement rules. And what we've discovered is that Gifford has not conducted a strategic pricing review in recent memory. And so we need to change that in FY27. We are going to need help to do that. We are not capable of doing that on our own in a timely way. And so we're going to have to engage a third-party consultant to conduct a comprehensive pricing study. And at the end of that, we should have prices that are rational, defensible, affordable, and transparent. As part of that work, we've talked to Blue Cross Blue Shield, and we are committed to moving away from a percent of charges pricing with them and moving to a fee schedule. That's work that we've committed to with Dr. Weigel and with Beth, and we're 100% going to do in 2027. They've been very patient as we're trying to navigate getting this budget together, but we think it's time to move to a new fee schedule with Blue Cross Blue Shield. And again, we'd hope to use this work over time in our related efficiency work to improve pricing and patient flow in Vermont. Also, we're going to expand our financial assistance policies in FY27 with a goal of having Vermonters pay less. Right now, to the extent we can get patients to fill out our financial aid forms, many of them qualify. And so we need to do expanded outreach to increase that number, particularly if we're going to pair it with financial policy changes. We're going to extend free care from 250% to 300% of the federal poverty level, and then increase the discounts between 3 and 350% of FPL and 350 and 400% of FPL. But much of this comes down to trying to get people to understand that this is available and that it's worth their while to work with us to get that paperwork filed and to get the financial assistance that they need and deserve. Now, we're going to pivot from that into our actual performance. And I just wanted to put this slide up here as a scorecard to tell you, okay, how are we doing? Because mostly the argument that Gifford is making is from where we were after the Oliver Wyman report 2 years ago, and that report turned out to be a difficult but necessary gift, demonstrating that we needed to do better. Can you trust us to continue to make positive improvement for our organization and the patients we serve? And so over time, if you look, we are improving our performance. We went from a loss of almost $6 million in FY25. We projected a $2.9 million loss when we filed our income statement in adaptive this winter. Taking a look at the last 9 months of our financials, when that was filed was sort of the low point of our performance this year. If you measure with our actual financials through the end of June, our loss is around 1.5 million, which is close to what we budgeted after cost allocation changes. And then our FY27 budget shows that margin of just over 1%. And then we're also showing you what it is enterprise-wise, once you factor in the FQHC and the retirement community and other related things. There was a loss of almost $9.5 million in FY25. Our budget in FY26 was about anticipating a loss of $3.143 million as part of a multi-year turnaround. And I'm pleased to report that through 3 quarters this year, we're within $15,000 of budget for the overall organization. And as I said before, in FY27, we must get to a positive margin and continue to make progress. So how are we going to do that? And we're using multiple strategies to return to financial sustainability. If you're like me and you can't help but click on all the links on the Green Mountain Care Board website to see what other hospitals are doing, you might notice these 6 strategies from another one of our filings. This year, the Green Mountain Care Board asked us to submit an operating expense plan for the next 5 years. That was a great exercise. Candidly, we're just able to talk about it at a high level. And our responses in that plan are the exact same strategies that we're using right now. We need to right-size clinical resources, increase productivity, create our own workforce, because we know nobody's going to show up with sufficient rural healthcare workforce. We need to build our own. We need to make sure we're managing our vendors properly, given the complexity of healthcare and the expense of those contracts. We need to somehow gain the benefits of scale without losing independence, and we need to reduce subsidies. And here I'm using the word subsidies in a very particular way. In any healthcare organization, there are service lines that make money and service lines that lose money. And here, the way that Gifford thinks about it is that there's the hospital and then there's the other pieces of our business. And we have to make sure that those other pieces of our business that are not the hospital are functioning as close to break even or better as they possibly can be, so that we're not putting undue strain on the hospital's finances and the patients that use that hospital. And so here we decided to share with you as a board all of our efficiency and productivity work beyond the everyday work of continuous process improvement in service of you knowing exactly the type of things that we're working on right now, so we can receive the largest financial benefits starting in October when FY27 begins. And so these changes include increasing our average daily census. When we look at Dartmouth and UVM and other local hospitals, we believe there's an opportunity to improve patient flow for Vermont and Vermonters while also increasing our average daily census. We've made the decision to consolidate our operating room from 5 days a week to 4, and Meg McCormick will talk about that in a moment. We're reducing general surgery labor as part of our general desire to increase productivity while lowering cost. We've seen some growth in orthopedic surgery volume. We expect that to continue. We are reducing contract labor, but of course that has an offset since we're hiring our own people, and we feel like we're making good progress on that. We are closing our Berlin specialty clinic. For those who do not know, for a long time, Gifford Healthcare has had a specialty clinic in Berlin, maybe a mile and a half from CVMC. That clinic has been very low volume, and that just does not seem like an appropriate use of resources given the fact that there's a hospital right there. So we're moving the clinical staff from Berlin back to Randolph, where we routinely can keep them busy. When we move out from the hospital view to the full enterprise view, we have improved FQHC access by 7.5% this past year in terms of productivity, and we think we've forecasted that to improve. As we discussed last year, revenue cycle continues to be a problem since our EHR implementation, and we are committed to making sure that that improves this year. We think better collections and billing will improve our bottom line. Again, as I mentioned subsidies a moment ago, we have a targeted improvement of $500,000 in the subsidies from the hospital to other pieces of our organization, and we have a plan to get there. We also need to contain benefit costs. Healthcare in Vermont is not just unaffordable for many Vermonters, it's unaffordable for many businesses, including ours. And so we know that we need to trim benefit costs in the coming year. We have that retirement community, and we think there are things that we can do to improve its financial performance over the coming year, including restructuring some of that debt. Even though one care has gone away, we still belong to an ACO, and we think our performance with Alidate is quite good. And we think there'll be a positive financial impact in FY27. And then, of course, we continue to try to replace contract providers with home team providers. And we've been successful at doing that with our Psych NP staff. And we think that will have a positive impact on our bottom line. And we're looking to grow our mental health and counseling services. And then, of course, the state of Vermont does an annual FQHC rate increase, which is required by the federal government. And that will have a positive impact on primary care generally and at Gifford specifically. So I'm going to hand the presentation over for a moment to our Vice President of Clinical Services, Meg McCormick, because she has led the process over the last year to try to right-size our staffing to meet community need. And this is hugely important. Just backing up for 1 second, Kaufman Hall did really good work on Vermont's healthcare system. And part of what they said was, well, you need to pursue efficiency and regionalization. But much of the value and savings needs to come inside the 4 walls of hospitals. You simply need to get more efficient and productive. And so every single day we've tried to honor that goal. A lot of times my editorial comment about Vermont's healthcare system is that we're waiting for some sort of Staples easy button to fix all our problems. And that's never going to work. As I tell my staff, pray but move your feet. Find the hard work to do every single day to improve our organization, grow access, and constrain costs. And so Meg's going to talk a little bit about how we've done that with our providers. Meg?
Thanks, Michael. So we measure service line capacity using a few different data points. We look at provider productivity, we look at historical and projected visit volume, and we look at referral trends. And using that data, we're able to quantify the actual demand for visits and then compare it to the number of available visits per year per provider. In some cases, we expect volume to remain constant or consistent. In other cases, we see there's potential for growth, and in those cases, we leave space for that growth. We also track their next available appointment to make sure that the access we're maintaining is timely. And we talk very openly with our providers about productivity and what it means for access. And at the end of the day, ultimately, the math showed us that we could see the same number of patients with fewer resources. It's really that simple. Of course, as we continue to measure capacity at the service line level, we can always expand. We can always increase staffing to meet the demand as needed. But right now, we're looking at what the actual demand is, and we're staffing to align there.
Great, thank you, Meg. And that work is going to continue in FY27. And I want to emphasize a point that Meg made. We're trying to right size our operations for the patient demand that we have today. If at any point we're able to grow that demand, or we're able to offer Vermonters quicker access at a better price, we could scale that up. But waiting around for that to happen is inefficient with resources that are quite scarce in terms of provider time, staff time, and financial resources. I want to talk a little bit about one of our other strategies, which is increasing our inpatient daily census. And for me, the reason why we're digging down on this particular item is, number one, it's a very important assumption in our budget. But two, if I were sitting in the seat of a regulator, I would say, okay, that's fine that you want to do that. How the heck are you going to do that? What is the basis for that assumption? Because really, as leaders at Gifford, we're trying to only focus on things that we can actually do. So I want to invite my Vice President of Nursing, Quality, and Patient Safety, Sarah Simeone, to talk a little bit about the methodological basis for this assumption, the type of work we're doing to try to get there. Sarah?
Thank you, Michael. So as Michael said, it is very important to us that the goals that we are setting are measurable and attainable. So when we talk about increasing our average daily census, we have set a target of increasing to 17 patients. We believe that is achievable because of the position that we hold within the health system that is very important, which is we work in collaboration with the academic medical centers in the area and the acute care hospitals in the area to serve as a pressure release valve to help to offload patients that are appropriate for the level of care that Gifford can provide. We have efforts in doing that both in transferring patients that are in an acute level of stay and need a few more days acute level of stay and could do that at Gifford. But more so, we work very hard to identify patients who are ready for discharge from acute stay and need swing bed or rehab status. As a critical access hospital, we can use our beds either as acute beds or in a skilled nursing level of care, which we refer to as swing. So in order to understand what we believe we truly can achieve, we have been monitoring for the last year the number of referrals that we receive for requests for swing beds, how often, what percentage of those referrals we accept, how many of the accepted referrals we actually admit. And what we have learned is that we typically miss admitting 5 swing referrals a month. Swing patients have an average length of stay of 10 days, which means we miss 50 patient days per month that are available to us, which is, we believe, recovering those missed days is what will help us to overall increase our average daily census. And that is what has driven the target that we have identified for this year.
Thank you, Sarah. While we're talking about these transfers and the work that we've done, it's not a story of Gifford alone. We have to thank our local EMS provider for all the work they've done transporting people. We have to thank Dartmouth for treating us as if we were an affiliate in service of creating patient flow, even though we are independent. And we have to thank UVM as well. Though we've had more luck with Dartmouth transfers so far, our relationship with UVM is strong and getting better. And it seems very clear to me that Dr. Leffler has told his team at all levels that you need to be great partners. And so we're seeing that at a lot of different levels in our organization. So we talked a little bit about the strategy of building a rural workforce, because as I'm sure you hear every year as regulators, traveler expenses, contract labor is very, very expensive. And there are times where we feel as if it might affect the quality of care or the way in which our patients perceive the quality of care. I want to make sure for any Gifford team member watching, I'm not taking a swipe at contract labor. Our hospital could not run without them at the present time. But over the long term, I think we'd all agree getting people that want to be at Gifford over the long term is the best way to build a workforce. And so here we want to target and talk about a number of initiatives. Number one, we're using our New England Collaborative Health Network, which you'll hear more about in a minute, to reduce the cost of travelers when we need them. Purchasing at scale is both obvious and important in healthcare. And joining NACHN and leveraging that platform has allowed us to bring traveler rates down. Number two, we're working with other hospitals and FQHCs to launch the Maple Mountain, Vermont Family Medicine Residency Program. We've been talking about this for a few years. The program was accredited in 2025, but it lacked funding. I'm pleased to report that between the state of Vermont and the Rural Health Transformation Program, that we now have sufficient funds for that program. We are recruiting residents, and we expect to have the first residents on campus in Vermont starting in July of 2027. Also, we have a nurse residency program, which is really an extended onboarding program, which we started ourselves last year in the face of large travel contract staff costs. That program had 8 people in year 1 and now has 9 people starting in year 2. And we're very pleased, and retention has been good. We also have a medical assistant program. Medical assistants are hugely important to making clinics function appropriately and serves as a powerful gateway to a career in healthcare. And we're doing the same with LNAs across the organization. Also, it does take resources. While we have not given an across-the-board increase in this fiscal year so far, given our financial condition, we've done over 120 targeted market increases. We do feel like Gifford was behind in some positions, and we need to make strategic investments. And so when we turn to our patients and talk to them about the cost of healthcare, we can be assured that we're making the right investment at the right time to make sure we have a great workforce. So I mentioned a moment ago the New England Collaborative Health Network. And although I haven't watched Copley's hearing, I imagine Joe Wooden talked about it at length. It's one of his passion projects. And when he started it a few years ago, to be candid, you didn't know whether it was going to fly or just be, another talking point in the healthcare landscape. I'm pleased to report that the efforts of Joe and others are really starting to bear fruit. And while we pursue regionalization and collaboration and reform through multiple channels, New England Collaborative Health Network is really starting to become one of the primary channels by which we combine resources with others. As I'm sure Joe told you, there are now 17 members, hospitals in New Hampshire, Vermont, and New York, home health agencies and FQHCs that are sharing costs and services and capabilities and talking about the future together so you can get the benefit of scale without giving up fully your independence. And so we'll get more into NECHN in a moment, but we do have other important partnerships. We have the ACO, Aledade, Dartmouth Health, with both the transfers and we share some orthopedic surgery staffing. UVM partnerships are starting to grow, and we're really focused on hematology and oncology right now. They're not reflected in the budget, but they're part of what we're talking about. And then I want to give a special thank you to Rutland Regional and Judy Fox and her team. And we were really in a bind for radiology services after the departure of our last radiologist after the Oliver Wyman report. And we went and contracted with a national outfit and understood right away that we needed a local partner. And so Rutland Regional and their in-house radiology service, Rutland Radiology, it's independent, but their one customer is RRMC, have just been wonderful. And now we're engaged in serious discussions about sharing other services and service lines with them. When I think about Vermont's previous healthcare reform efforts like OneCare ACO, I think about the difference between a coalition of the willing and a coalition of the able. Vermont, as you all know, is very good at convening people. The key question is, can you take action and make changes? And in Rutland, we found a group of leaders and a hospital that's quite capable of changes. And so those partnership discussions have been really excellent. And I just want to publicly say thank you to Judy and her team. Now, New England Collaborative, it has to be more than a talking point. It needs to increase in value over time to be worthwhile for all of us. And so far, the initial evidence is quite good. We share group purchasing, insurance, and benefits. And right now, the estimate that we have out of them is that we've saved over $1 million in FY26. Of course, we need to scrutinize all of this over time. The cost of membership is quite low. The cost in FY26 was about $40,000 for Gifford. We anticipate it'll be $31,000 in FY27 and reduced further sometimes by shared savings and dividends. So that means that there's a huge multiplier effect. I think everybody in the collaborative is so conscious that it should be about tangible results, not just coming together to talk about the future of healthcare in Vermont and elsewhere. And we're seeing with our members in New Hampshire and New York, the problems in rural healthcare are the same, and they don't observe geographic boundaries. Like all of us are in this to make sure that rural healthcare is sustained And we know that we need friends to make it sustainable over time. That network is growing, but it's not costing more for individual members. I think that's a really important point. So we're not paying for scale alone. We're able to share those costs. And as I said before, it's people are voting with their feet to come into the collaborative as opposed to either staying out or leaving. And then we're all open to future possibilities. We know that there's more we can do to share services and create value. And so the conversation is going from the easy stuff, in a way, group purchasing insurance, to like how we could share other services and other business functions as a group. And so the New England Collaborative continues to identify shared opportunities for the future. Right now, we have RFPs out for other types of insurance, dental benefits and supplies, radiology services, and a collection agency RFP. Now, one of the great parts about the collaborative is that people tend to, or are only required to jump in. People are not required to jump in on everything. People get in on the things that make the most sense. And so, for example, we had made at Gifford a different move on radiology prior to the collaborative trying to combine for radiology services. And so since we're not part of a formal network, we're not forced to try to change again. Now, of course, we'll monitor the performance of our new radiology agreement with Rutland, which starts in October over time. But we'll also monitor the performance of any radiology shared services that happen within NECHN and always evaluate what's best for us and our patients. And then, of course, NECHN is working together to evaluate and implement rural health transformation opportunities. So we're looking into a shared human resources information system, potentially a shared electronic health record, and also issues around workforce and telehealth. Now, another strategy of ours to make sure that the hospital is sustainable is reducing subsidies to other business lines. And again, I want to be careful here. We think of Gifford as one corporation, right? And some parts of it produce a positive margin and other parts of it produce a negative margin. But historically, the hospital has been profitable and able to carry other parts of our health system. And we think to be sustainable over time, that the other pieces, the non-hospital pieces of our health system, need to improve and need to perform better. And so we wanted to give you some insight into four of the core pieces of our health system that over time have required subsidy. So first, the FQHC. Primary care is hugely important to Vermont. We're enormously proud of our identity as an FQHC. I get calls regularly from health systems across the country to talk about whether critical access hospitals and FQHCs should fuse in some way. And we think the setup works very, very well for us and our patients. Now, over time, the FQHC has required large subsidies. We think between the cost reallocation and improved performance, then the FY26, the FQHC will basically break even, and in 27 will not require a subsidy. If you hear any background noise, that's because there's a helicopter landing right now about 75 feet from my office. I'm super grateful for our partners coming in to take a patient. To the nursing home, running a 30-bed nursing home sustainably is very difficult. You simply do not have the scale to do that. And so as you can see on the chart, over the last couple of years, we anticipated quite large subsidies for the nursing home. Now in FY25, that number is zero because of state grant funding. But as you can see in our FY26 budget, that subsidy was supposed to be 1.83 million. We've engaged in an enormous amount of process improvement when it comes to staffing and how we care for people and reducing travelers to the point where in June, our traveler budget for that nursing home was $70,000 and the actual spending was $16,000. And so we're doing better over time. And that's even accounting for the fact that $383,000 worth of that cost reallocation were sent back to the nursing home. And so, we anticipate about $500,000 worth of progress this year, but if you add back the cost allocation, it's getting towards $1 million of positive improvement in the nursing home. And we'll talk about how we did that in a minute. We've had a childcare facility for many, many years at Gifford. We are enormously proud of it, but it requires deep subsidization. And we have a strategy to work on that in FY27. Essentially, the state of Vermont has capped childcare tuition, and many childcare providers rebase their tuition prior to that state law coming into effect. Gifford, prior to my leadership, did not engage in a tuition rebalancing to better match costs and revenue. And so in the state budget, there's a provision that allows the commissioner for the Department for Children and Families to approve tuition increases beyond the normal allowable amount if an organization had not previously rebalanced their tuition. And so we think between state subsidies and rebalancing that we can improve the bottom line of the corporation without having the maximum impact on the families that use that facility. We really want to keep that facility open. It is hugely important for our employees and their families, but we must face economic reality. And in my opinion, healthcare organizations have put off hard decisions for a long time. I've told my leadership team that we cannot do that. There's a real tendency in healthcare to say, we'll deal with this later. And later is right now. Like, we need to make the hard decisions and the improvements necessary to make sure that this hospital and healthcare system is sustainable over the long haul. And then adult day. You probably read about recent closures of adult day facilities in Vermont. Adult daycare is hugely important. People get a good meal. They get proper medication management. They get great care. Caregivers get respite. That data doesn't neatly align with our stories. That subsidy is not coming down. We think that the real key there is that given the small space we have for adult day, that we don't have enough space to scale up the program to meet community need and to break even or do better. I'm pleased to report that yesterday Gifford was approved for a Rural Health Transformation Program grant that would allow us to expand our adult day space. And we think having more people as participants in our adult day program will lead to better financial results and sustainability over time. Now, I mentioned the improvement at the Medic Nursing Home, and about a year ago, Heather Impey became the new leader of that facility. And she has done an amazing job trying to make that as efficient as it can be. My only instruction to her when she took the position was, go tell me what peak performance looks like. And well, we're not there. We've recently gone from 2 stars to 4 stars, and the financial performance is really picking up speed. And so I just invite Heather to speak for a moment about the type of things that she's done at Medic. And part of the point of that is to demonstrate to ourselves and to you that this isn't magic, that the work of efficiency is the everyday work of improvement, and it can and should be done by Vermont's healthcare organizations. Heather?
I'm going to interrupt just for 1 second, just being mindful of the time. We're about 45 minutes in. We'd like to keep these around 30 minutes. So just being respectful of time, I want you to finish, but just keep an eye on the clock, please.
Yes, Mr. Chairman, we'll be done in less than 5 minutes.
Great, thank you.
Thank you, Michael. In support of the organizational efforts towards efficiency and sustainability, looking at our nursing home, there were some really practical improvements that we were able to put in place, streamlining our room turnover process to allow for reduction in lost revenue, as well as offering additional care days to the community members who were in need. We optimized our staffing model, maintaining our CMS 5-star staffing rating, but being able to reduce our reliance on travelers. And we really took a look at our payer mix management with some strategy as we had room turnover to help with revenue growth. It appears Michael is having difficulty.
Might be the helicopter. Michael, you might know this hack if you can hear me, but shutting off your camera sometimes helps. Yep. We can see you again.
It appears I got kicked off. I apologize for that. So I assume Heather did a wonderful job.
She did in your back.
Right.
Thanks.
Great. Thank you. Great. So now we did articulate both in our narrative and in the slides the risks we have, particularly around the revenue cycle. This has been a chronic issue at Gifford. In 2027 is the year to solve it. We have exited a contract with our current vendor. We've assembled a task force, and we're hoping to have a decision about the next 90 days on how to proceed. We're not waiting 90 days to fix things. We think the task force can identify some really common sense improvements. We, of course, have debt with JP Morgan. They've been excellent partners with us, but they have a put option again next spring. And so we're going to have to do work this fall and winter to refinance that debt. Of course, as you saw in our presentation, that some of our budget rests on utilization assumptions, and so they may or may not come true. So that serves as risk. There's generic risk in the federal policy environment right now. And then all the typical ones, wage pressure and age of plant remain a real concern, particularly with capital. And then the childcare subsidy. I noted that the state of Vermont changed its laws to allow us to rebase our tuition. But of course, the commissioner of the Department for Children and Families has the final say in that. And so it's somewhat out of our control. And then given the time, I just say that, we look at this hearing every year as an opportunity to basically take an exam and find out how we're doing. And this isn't the end of the process for us, it's the beginning. We feel like FY27 puts us back in the game. It's not the finish line, it's the foundation for future success. And the message that we think we send out to the rest of the healthcare system is that efficiency is the work of healthcare reform. It's not austerity. It's not shrinking things for the sake of shrinking things. We would note that in our budget that we're not reducing any service line, and we remain fiercely proud of our birthing center. And that a hospital needs to be efficient and be financially strong to be that meaningful partner in healthcare reform. We believe we're already demonstrating what this looks like, but as you've seen in the slides, we have a lot of work to do in the coming fiscal year. And to get to that transformation budget in FY28, we feel that we have to hit our marks in FY27. And the primary way that you could help us would be approving our budget as submitted. So with that, and apologies for going over time, I would stop sharing my screen so I can actually see all of you. And our team would be happy to answer your questions. Thank you very much.
All right, many thanks for that overview and sharing a lot of the positives that you've been working on. I'll start with member Teachat for her questions.
Great, thank you. Thank you for your presentation. Some of these are just clarifications, and some of them are just digging a little deeper into what you and your team presented. I did want to ask you about the, I'll just start here, the Medicare bad debt for all the previous years, which were FY22 through 24, I believe. Were you able to claim the full amount for all of the previous years, or was there some you weren't able to apply for?
So my understanding, and Bill King can jump in if I have this wrong, is Gifford was not claiming that in the cost report for reasons I do not understand. We engaged in a project to try to get that started again. We used outside labor over the summer, and I believe they got some, but not all of it back, both because of time and then system limitations. There was an EHR conversion in the middle of that. That's the best of my understanding in that project. Our hope is not to leave multiple years of bad debt on the vine again. Bill,
Okay.
if you have anything to add, feel free to jump in.
No, Michael, that was exactly correct. But we do have more that can be claimed. So it's not lost, it's just delayed.
Okay, so while I did appreciate that you're working on what FY27 is your kind of base year going forward, so you'll know what you typically are able to request, and then what is sort of one time going back and trying to get previous years.
At this point in time, I don't have those figures, but we can submit that as a written request and split those out into a table for you.
Great, thank you. I was just trying to figure out the one time versus the kind of ongoing amount that you would typically get. I want to jump to your new relationship with Rutland Radiology that you talked about. And I was wondering if in the big picture, this is going to increase or decrease radiology costs for the patient.
So I want to be very careful here, right? Because I'm going to share my understanding with you, but I don't have perfect access to their prices and what other options people would have. Our point of view is that for operational decisions, the thing that makes the most sense to us is to dispense with that staffing expense. And then they would bill the pro fees and we would bill the facility fees. Although I don't know their pricing structure, I have a strong hypothesis that their fees would be lower than that of a critical access hospital. And so I have a hypothesis that this would not cost Vermonters more. I have not done a specific analysis with their pricing structure and our utilization to take a look at that. It has an impact on the provider tax in the sense that They are not subject to the provider tax, and we are. And so I just want to be very clear about that. But this was more about operational efficiency and making sure that we were better utilizing resources in state instead of using third parties from across the nation.
I appreciated the explanation you provided us, and it was very thorough. And that was the one piece I couldn't figure out from what you gave us. So, let's see. I wanted to ask about your transfers from other hospitals that you provided all the information for. Are these inpatient or observation stays or both?
I'd invite Sarah Simeone to answer that question.
When we transfer a patient from an outside hospital to Gifford, it is always a patient that is either in an inpatient acute level of stay or an inpatient swing or skilled nursing level of stay. We're not transferring any patients in observation stay.
Okay.
Sarah, we also sometimes transfer acutes to acutes, particularly if we have an acute that needs one procedure at Dartmouth or UVM, we'll ship them out and now bring them back. I think previously it's my understanding once somebody was gone, they were gone, but we're working better and more collaboratively with those academic medical centers to say they need this one thing, and then you need that bed back, and we would like that patient. And so there's more coordination happening at that level as well.
And I expect that probably helps local patients who would prefer to be closer to home for their recovery.
Yeah,
Yes,
both in terms of family visiting, quality of care, and our amazing food and nutrition services. Like we'll compete against any cafeteria in the state.
That sounds excellent. I wanted you to just expand a little bit more on the OR schedule shift from 5 days to 4 days. And I appreciated I think it works together with the discussion you had earlier on FTEs and sort of I don't know the right word to use, but, reworking that so you didn't change access. You're just, being more efficient. Is that the kind of same thing you're doing with the OR schedule, and are those two pieces working together?
That's exactly right. And I'd invite Meg McCormick to talk about that.
Sure. So yes, first of all, in right sizing our general surgery team from 2.8 to 1.8, we were also able to right size the OR blocks that they were using to better align with actual data, actual use. But we also looked at the way that we were staffing our birthing center from a CRNA standpoint and took the opportunity to take both of those changes and condense from 5 days to 4 days. In doing so, we anticipate going from what our current OR utilization is, which is around 60%, up and bringing that up to 75% utilization, which still allows room for growth, allows us to flex. And also in doing so, we've reduced the number of hours of contracted CRNA staffing by 21%, while only reducing the OR block availability by 7%. Again, that's because of the way that the birthing center is being covered. And so we took the opportunity with the adjustment in general surgery staffing to look at the OR schedule and see where we could be more efficient.
Okay, that's helpful. And then since we're talking about it here, I wanted to ask about clinical productivity. So the information you provided to us is before or after this right sizing that you did. And then there were some areas where you had pretty low productivity. So if you could talk about that as well.
Sure. So I think what you're asking is, actually, can you clarify for me exactly what
Sure.
you'd like for me to speak about related to productivity?
Sure. There were two questions kind of mushed together. So the first
Sure.
one is the clinical productivity numbers that are in the information you provided us. Are those before or after you right-sized your FTEs? That's one question.
Yeah, so I think that the specific data that we shared with you from my recollection is related to our FQHC in terms of patients per hour. And what I'll say there is that's regardless of right sizing. So we are looking at productivity and volume in two different ways. We're looking to both improve increase the number of patients seen by our existing resources, and to make sure that we have the right number of resources. So they're kind of two different paths towards becoming more efficient. Both of those taking, improving productivity and adjusting staffing, move us in that direction. Does that clarify?
I think so. I'm not sure it was just the FQHC because there was productivity for podiatry and obstetrics and a bunch of different areas. Then some of them, I should be able to pull up the sheet right now, but I can't find it, were lower than the national benchmarks, which you also provided.
Got it.
Sure.
I think Sarah, board member Teacher, you're talking about both our supplemental responses and the utilization spreadsheet that was submitted in adaptive.
Correct.
Okay, got it. I would defer to Bill as far as the point in time that those were submitted. I would say that there have been some ups and downs, like neurology, you see go super high up. But those are basically a point in time halfway through this fiscal year. And so, I think that they reflect some of our progress, but not all of our progress so far.
Okay. Yep, that does answer the question. Helpful. I was just wondering if there was more to come, or if this was before you made your changes.
I think as a general matter, there needs to be, productivity needs to rise. I think we're trying to figure out with our team how that happens without harming the culture of this place, right? Which is of course the trick in healthcare. And so that's where we're trying to bring people along on that journey.
Okay, great. Thank you. And the last question I had was about the primary care reimbursement at the FQHC versus the reduction in the hospital prices. And I think I was a little confused about how that is working. So if you could explain that, it would be helpful.
Bill, go right ahead.
Yep. So the reduction in the hospital is we threw in some reduction in net revenue, because we're going to be entering into negotiations with one of our major payers to move more towards a fee schedule for lab and radiology, and to remain whole. As part of those negotiations, we're going to ask for higher FQHC reimbursement.
Okay, and so this is where I'm confused about what's the hospital and what is the rest of your organization. So you're increasing revenue to the FQHC, which reduces the subsidy, I'm presuming, to the FQHC?
That is correct.
Okay. Okay,
Yep.
that's
Based
helpful.
on our preliminary discussions with Blue Cross Blue Shield and Beth and Courtney and Dr. Wiegel have been good partners. It's been a broad discussion of, hey, we understand the Green Mountain Care Board's guidance on commercial insurance and commercial reimbursement. We plan on meeting that. There's a good discussion to be had about the future of primary care. And as we know, we come in as kind of an odd duck from a corporate basis, but we think of it as one company, and that's one of the assumptions we're making in the budget, the overall budget.
Okay, no, that's helpful. And I get that your corporate structure is different and your relationship with the FQHC is different. So it's something your hospital can do that others can't, but I was just curious about how it was working. Let me look at my questions one more time to make sure that I haven't missed anything that I was interested in learning more about. I guess, and this is a follow-up, it's a bigger picture question about your entire organization. So do you believe that eventually the hospital will not need to subsidize the FQHC in the nursing home, but will continue on some of the other entities? Or are there some areas where you'll always have to subsidize, like the nursing home?
So that's a great question. It's one that I think our board of directors, finance committee, and senior management talk about a lot. I think that I have a hypothesis about that, which I'm speaking for myself here. I think the FQHC has to stand on its own 2 feet over time. I just think, they do as independent organizations, and they need to hear. I think that we're trying to make it so things like our adult daycare and our childcare facility break even. That's a journey to get there. The nursing home, I think we need to do the best job we can, but breaking even with a 30-bed nursing home is really, really hard without radical rate changes. The instructions I've given Heather are, hey, I know that breaking even with 30 beds is hard, but we can't lose $2 million a year. Like, that's just inappropriate. So you need to go on a journey to tell me what we lose, what the benchmark is under real good performance, so we understand what the actual carrying costs of a 30-bed nursing home are. I think we're getting closer to that. But 2 million was, you just looked at it and said, nope, this isn't, hey, 30 beds, what you can do. This is poor performance, and we need to deal with poor performance. So I think, to answer your question, some level of subsidy will definitely be required at the nursing home, but we think overall those subsidies need to come down, particularly in those other entities.
Great. That's super helpful. You're running a pretty complicated organization with all these different kind of unique entities. My last question was about the quality, and I really do appreciate Gifford being a 5-star quality entity. I think that's great for Vermont and for your organization. I did go through and read sort of the different areas that CMS looks at, and it looks like because you're so small, there's a lot they can't rate or grade. Is that typical for you, or is it a little bit unique to this? It doesn't take away from the 5 stars. I just was curious about that.
No, Sarah, feel free to jump in.
It is not atypical for organizations of our size. I mean, it is expected because because those ratings are applied to hospitals across the nation. Hospitals from, a 10-bed hospital to us with 25-bed critical access hospital to a 1,000-bed hospital. And so this really is driven by having the volume that makes the ability to calculate the statistic in a reasonable way. So you are correct. There are a lot of the measures that we are exempt from because our volume is too low to make the measure meaningful, which means that what we know is that our star rating is driven primarily by our high performance inpatient experience ratings. And we dig deep into that, and the star ratings always lag. That is from 2024, just so the board is aware of how much of a lag there is. And that is primarily because of our high performance of our birthing center and the excellent patient experience that our folks have on the birthing center.
Great. Thank you. Those were all my questions. It was helpful to have the expansion there on so I can understand it a little better. I will pass it back to you, Chair Foster.
Great, thanks. Member Walsh.
Thank you, and good morning. Thanks for the presentation. I appreciate the clarity and the work that you're doing. And I also wanted to just take a moment to congratulate you on the 5 stars. That's not an easy attainment, even when there are low numbers and it's hard to see into everything. Some of those measures, it only takes one never event to lose a star. So congratulations.
Thank you.
Just a few questions. Your presentation clarified one of my allocation questions. The 1.45 million of higher hospital expense was a reclassification. In thinking about the FY27 changes, if we lump those operating expenses or costs into 3 buckets, a cost moved, a cost was avoided, or a recurring cost was eliminated. Can you help me sort through how you would divide that up proportionally? What's actually going on? It seems like there's a lot of movement, but it's hard to follow through to cost actually being eliminated. Can you help me with that?
Of course, and I want to make sure I understand the question. So, Board Member Walsh, it's, hey, you've reclassified these costs primarily for 2 reasons. One, to reduce the value of the Medicare payable and to have a stronger methodology for your cost allocation. And of that 1.45 million, what's ongoing, what can be reduced, what might it spend? When I take a look at the cost allocation methodology, I look at this 1.45 million as really core administrative costs. So how, for example, we have a 4-person human resources team. This is about how the 4 of them get split up and allocated among the corporations. You have your basic back office financial functions, how they get split up. And before it was done by time series, every couple of weeks, people had to log into a spreadsheet, tell us about how they spent their time, and then they got allocated. And I'm oversimplifying a little, but that is the system that I inherited. And to us, that just wasn't rational. So the impetus to do this was the payable, but it really was work that needed to be done. So I expect this to be kind of like the new normal in expenses within the hospital, and they'll be subject to our general cost containment efforts, but they're not one-time things or things that you can just knock out in 1 year. It really is about what's the right allocation of the pie chart, given the corporate structure that we have.
That's helpful. And let's keep talking about it for a moment. So let's imagine, for simplicity's sake, that you're an entity. You are an enterprise with 3 organizations, and within one of those organizations, there used to be a 4-member team, and you reallocated those 4 members so that just 2 were at the home and 2 more left to the other 2 entities. You could rightly claim a reduction of 2 FTEs at the home office, if you will. But for the enterprise, there's still all 4. So what I'm trying to follow through on is how much of the changes that you're talking about have been movement of cost versus reduction in operating expense. Can you, and I know you won't be able to arrive at a number in this conversation, but I'm just trying to probe how you're thinking about those things.
Yeah, I appreciate your question, and it's a good one, and we tried to address it in our slides. I know it's tough. I kind of drone on and on, but that's why we pointed out, hey, this is the Gifford Medical Center performance financially so far this year, and here's the actual overall corporate performance where we're within $15,000 of budget. Here's where Gifford Medical Center, it's 3% up on expense, but it's 2.1% for the whole organization, to try to convey that this is an accounting maneuver. It doesn't have a functional impact on the day-to-day operations over the overall bucket of expenses in the corporation. We know we need to manage that bucket better, and we know that you are going to hold us accountable to that, particularly with the operation and expense management plan this year. But it really, there's not a shell game between divisions. It's we're trying to be really transparent about here's where this shook out, which is by and large 1.45 million up on the hospital and 383,000 up on the nursing home. I mean, stated another way, the price of operating the hospital had been understated potentially for a number of years.
Yeah.
And this is just recognizing a different way to account for those costs. And we just feel like a more honest way, and then we have to be transparent with you about it.
Yep, I appreciate that. You're going through some changing with how you're allocating, and we'll be able to consider this the new normal as you described, or the base. And then we can watch that going forward, that we wouldn't expect there to be a lot of maneuvering back and forth, but actual reductions, or not always reductions, avoided growth, operating expense discipline is what we'd be looking for.
Yes, and if we came in next year with a radical change to the hospital's cost structure and pointed to our corporate structure, it'd be very fair of all of you to say, nope, no. Last year you said that you rebased your expenses, and now we have a new normal that we can measure against with fidelity going forward. If we had a big change next year, it should be due to an individual driver at the actual corporate level.
Yep. Thanks. One more question here. I saw the slide on clinical staffing. I couldn't tell what number it was, but in some of those you had reductions of 0.3, 0.6 FTE. And this is along the same lines with, I understand from my clinical time, I may have reduced clinical time in orthopedics to move to the spine center for a portion of my clinical time. That would show lower clinical time in orthopedics. But for the organization, there's still the 1 FTE. I'm just in a different hallway. And so I'm wondering how you think about that with that slide that you had with reductions and partial FTEs. Are they actual lasting reductions, or are they movement within the organization?
I would say, I'm going to hand this over to Meg. I'd say the short answer is yes, but I'm going to hand it to Meg.
Yeah, almost all of those examples where there's a reduction were either a a reduction moving forward. That FTE is no longer here. And there is one example, rheumatology, that is similar to what you're describing, where originally, my predecessor had planned for that to be full-time. The data that we can see shows that we did not need full-time rheumatology. At least right now, we need around a 0.4, because that provider had actually moved from primary care to rheumatology. And there's demand in primary care. We said, let's take advantage of this and the willingness of this provider to really help out across the organization. And so that's the one example where we did retain that FTE. But I'm looking at the slide now, so I don't misspeak. All of the others that I see here are simply reductions.
Okay, great. I really appreciate the transparency you've put into this and the clarity that you've brought. And so going forward in years to come, answering the type of questions that I'm posing now would be a next level of insight into how you're doing what you're doing. And you're on a great trajectory. So understanding that at that deeper level would be really helpful to all of us. So like I said, you're on a great trajectory. My next question is about revenue cycle improvement. That, of course, can mean a lot of different things. It can mean collecting money that you're already owed. It can also mean changes to coding practices or utilization practices, which may or may not be a good thing, and it can be difficult to try to tease that out. Do you have a sense of about how much of the 1.99 million is due to better administration, that type of collecting, or preventing denials, recovering underpayments, versus changes in coding habits?
So let me provide a general answer and see if it meets your needs, or we can try to get more detailed. I very much appreciate what I take to be the spirit of your question, that rev cycle changes can be like a carnival funhouse mirror, and people can see whatever they want in that. I can explain exactly the situation at Gifford. We have a vendor that we had been working with since the go live of our electronic health record prior to my arrival. Performance was not good. We have both an issue of not all charges are dropping in the EHR, which is my understanding. And so we're just not billing for everything that we do. And then the nuts and bolts of producing clean claims and sending bills and collecting money is not close to industry standard. And so this past winter this past spring rather, we ran a procurement process and gave notice to our current vendor. What we're seeing there and evidence that it's not working is this cash collections have been low, and days in accounts receivable persisted at a high level and then spiked this spring. And so we really think this is the nuts and bolts of the revenue cycle. Are you dropping the correct codes? Are you actually getting a clean claim out the door and through a payer? Are people paying? Is it coming back in? If that sounds scarcely believable or overly simple, it's intended to. It's not in the spirit of revenue optimization and, how do we code to increase revenue. This is the nuts and bolts of the revenue cycle. And we just think that there's improvement. We've made some assumptions that we think are modest, but they're not allocated between, hey, coding acuity will increase or this service line will lift. It's basic performance in the revenue cycle.
Yep. And you brought in another term that I think they often get conflated. There's revenue cycle management, which is what we talk about with kind of a cash timing issue, like when bills go out, when they come in. There's also revenue optimization, which is, can we find a higher code for the service that's been using? If you could, it would, again, this is kind of, I'm asking more of someone because you're doing well, but if you could help tease those two things out for us in the future, seeing how you're doing it and seeing how you're presenting it clearly would help us ask better questions with other hospitals and do our job better, because we want the best revenue cycle management that's possible, but we also want to be mindful that some revenue optimization techniques maybe not the direction we want to go forward with from an affordability standpoint. So
Yeah.
just your help with those type of things, again, because you are
course.
presenting these things clearly.
I thank you. And we do not want a scenario where Vermonters pay $1.50 for something they used to pay $1 for. And we all know healthcare is way more than $1. We will take your feedback and work on it. Our new CFO, Chris Frauenhofer, one of his first assignments is a simplified revenue cycle dashboard that can help us understand
There we go.
where we're going and how that needs to be improved. And that's certainly a topic of discussion with the New England Collaborative Health Network of, hey, to the extent all of us have challenges in a certain business area, how do we come together? In the strategies for savings, I put it more generally, which is vendor management. Just to be very candid, I think vendor management has been a real weakness of Gifford over time. These are big, sophisticated, well-heeled vendors, and we have to demand more because it's Vermonters' money going to them. And so that's an area of improvement for us in the revenue cycle and elsewhere going forward.
Great. Super. Next question about your financial assistance eligibility. The eligibility isn't the same as access, full access to the system, right? You need to identify who's eligible. They have to know about it. They have to start the process, finish the process. It has to be assessed. Do you have a sense of your success rate with that? I saw on one side 33 to 44%, somewhere around there. I think we're known to be eligible, but that leaves off the fuller denominator of which it would be hard to track. How many are actually eligible? How many are actually aware of their eligibility? How many begin the process, complete the process? Those type of details. Are there any efforts underway to try to understand that better and to improve the process of identification through but to eligibility and then receiving some assistance?
Those efforts, we were chatting about that this morning. We felt like this would come up. Our community health team and population health team, I've got to work with our front desk to try to make this real because we find that many people that apply actually qualify. These policy changes will go into effect in the fall. And so I don't have a pat answer for you right now, but we know we have work to do with the community health team, front desk, and pop health team to try to get more people through this process. Right. And so we'd have to
Particularly
report
with-
back over time.
Yep, federal changes, the state changes. There's a lot going on that will likely make this a big deal for more and more people. So I think of the data collection like a funnel, and the funnel has steps. And so keeping track of each step of the process, where you see leaks from the funnel determines what interventions are needed. Right. And so that's the type of assessment that would be helpful.
And for 20 seconds, just this is not an answer, but to provide some context, one of the conversations we've had recently is, hey, do we have the right job scope for the people that work at our front desk? Right. We're asking them to take phone calls, get patients where they need to go, talk about financial assistance as the front of that. Like, how many things can you ask somebody to do? Or do you need to reclass that job market-wise to reflect the fact that you're asking those people to do a lot of different things? Because what we don't want is either a press release or a checkbox of like, oh yeah, we changed the policy, and then nothing changes. And so we're actively reevaluating like how we do that to try to give some momentum to the policy changes.
Right. Those are all the questions I have this morning. Thank you for your time. Good work. And again, congratulations on the 5 stars.
Thank you.
We're going to take a short little break and come back with the other board members. We'll just take a break for 2 minutes for folks. We'll come back 10:52. Thanks.
Thank you very much.
Okay, it looks like everyone's back, so we'll resume. I'll turn to either member Holmes or Merman if they have any questions.
Do you want to go first, Dave, or do you want me to go?
Either one's fine.
All right,
Go ahead.
I just have a couple, so I can hop in here. Good morning. It's good to see you all, and thanks for
Good morning.
the presentation this morning. Yeah, and I'll echo everybody else with the 5-star. Kudos. Obviously, being the only hospital in the state that's achieved that is remarkable and very much appreciated. I just have a couple questions, actually. One is around, I know you're experiencing some increased demand for ortho and allocating more OR time for ortho. And, I did pull up, not surprisingly, some of the clinical productivity data that you've submitted, and it does look like, you have room in there, hovering around the 10th percentile for productivity. And then I also look at urology, you're hovering around the 10th percentile there, which indicates that, there's obviously room in clinical productivity there. But I guess my question for you is, there is room to move and you are trying to increase clinical productivity, but how does this entry of the ambulatory surgery center 30, 40 minutes away from you, where they're going to be offering ortho and urology surgery in a brand new spanking facility, impact your long range plans to achieve that steady state and that financial sustainability? Particularly, you're relying, at least in this budget, on some of that increased demand for ortho, which we know is a rather high margin service. So really trying to understand how you're thinking the longer term with this new entrant.
Yeah, I appreciate the question. Thank you for the kudos. I'm going to talk for just a minute, and then to the extent Meg McCormick wants to jump in, she can. So we have actually had discussions with providers associated with that ambulatory surgical center. And just, we understand that we have open OR time. We want that resource to be used productively. As you note, Gifford can be more productive on a variety of levels. And the first question, and so we've talked to some of them about, would you, they've asked about the availability of our OR to do cases prior to the ASC coming online. And we're, of course, open to that, right? And the first thing we talk to them about is, where are your patients coming from? Because, do you expect them to be drawn from our HSA or from somewhere else? And as we've talked with them and looked at the data, they can speak for themselves, but the draw primarily seems to be picking off academic medical center cases. We've yet to see a persuasive case that the draw will be from the population we have. If they do, then we need to talk about, hey, this would be really challenging for us. I do think you're calling the right question over time, right? Like, how much demand is there really to go around through the whole system? But right now, our conversations with providers affiliated with that ASC idea would lead us to believe that we're not they don't believe that we're the primary mover of patients for them. I think this is one of those things, though, over time, we want to run a tighter operation where we really understand clinical community need, and to look in the mirror and say, hey, what are the essential services in our community? I think my wish in this whole healthcare reform process, starting with Oliver Wyman and going forward, is that Gifford's in a strong enough place to meet those conversations from a place of financial strength and efficiency, so it understands its options, not from a place of weakness where it really has no options or choices. We really want to be in control of whatever change is going to happen, because change is going to happen over time to Vermont's healthcare system. Meg, I don't know if you have more to add on that.
I would only add that building on what you said, those providers that we're in conversation with have already been practicing in that region. The care that's been demanded of them already exists. And so just to build on Michael's point around where the patients will come from, that brings us, we feel comfortable from that perspective, and it's good for patients to have another option. We see that as a good thing.
Yes, I'll add just one very brief thought. I promise to be very brief. I still think the primary problem that Vermont's healthcare system should be working on after affordability is getting the right patient to the right place at the right time. Because we still have this lumpy demand where some ORs are at 85+% capacity and some are lower. Is there any way we can move patients around? I think as we get to a more sophisticated place on reference-based pricing, we would love to work with someone like Blue Cross Blue Shield of Vermont to say, hey, the fixed costs of this place are what they are in a sense. Once you go through your round of efficiency work, what would be the right price to move people from places where they're really expensive to places where they're cheaper? We're not there yet, but that's where we're trying to go to try to deal with that demand issue.
Yeah, I mean, I think that's been the whole hope of the AHS transformation work is to move patients to the right place, least cost, highest quality centers of excellence. I mean, I think that's the work that's being led by AHS right now, and that is the hope. I guess I just would say, and obviously, I hope that what you're saying, bears fruit there. But when you're at the 10th percentile, there's not a lot of wiggle room if some of those patients are clawed away, right? I mean, you're not operating at the 80th percentile where a drop down is going to, you can bear that impact. When you're teetering at that such a low level, it does seem like it would be problematic if some of those patients were drawn to this new surgery center. But I guess time will tell. I just wondered how much of your future projections incorporated any potential, bypass of Gifford to the ambulatory surgery center. But it sounds like not
Yeah,
really.
the budget. No, I think we're aware of it. And then I think we're in discussions with those surgeons. And then we also had a slide of all the different budget initiatives. And I would say, Board Member Holmes, we are aware that a lot has to go right, but only a few things have to go wrong to put rural hospitals in jeopardy. And so we're really clear-eyed as a leadership group on that challenge. And so is our board of directors.
Yeah, the headwinds are high, strong. Let me just ask another question a little bit about the Rutland radiology. Is it interesting as we're learning more about outsourcing, particular service lines? And one of the pieces of information in there is that it will these services now will not be eligible for free and reduced care any longer. Can you talk a bit about that?
My understanding of the situation is that for the reads, they are Rutland Radiology's patients, right? And so while the service is happening here, Rutland Radiology is billing it. And so, we can only extend our financial aid policies to what we're billing. We don't extend it to what they're billing. And so I don't have more to add at this time at that, but that's the way I understand how that billing would work and why we're constrained in the discounts that would be offered for those professional services.
Okay, and this is also something I'm trying to understand, is when you contract to outsource a service line, why is there not conversation in that negotiated contract about expectations around free and reduced care for your, patients, or the rate cap, which is applied to your hospital, not applying to the services that are delivered effectively at your hospital, but by an outside organization? Like, why is that not part of the contract that you engage with these outsourced organizations?
To be honest, Board Member Holmes, at the time of contract formation with Rutland Radiology, the conversation was really focused on how do we get that service in here, particularly given the experience we're having with the current vendor. I think you're making a good point about the ambit of any future conversation, right? Like, hey, what are you gaining and what are you losing in this relationship? But just to be candid, for better or worse, that did not come up in that discussion with them.
Okay.
Also, to be candid, we're not in a huge position to make demands on that one, right? But your point's well taken. We'll have to think about that in any future contract discussion.
Yeah, I guess that was my final question, actually. It was just, you'd mentioned that you're in conversations with Rutland about potentially sharing other services and, or maybe you can be shopping around some of the outsourcing. And I would love to see that part of the conversation as you're going forward. Are there any other services that are currently outsourced?
So anesthesia is a primary one. And the primary saver within the consolidating operating room hours is by reducing the value of that anesthesia contract. So MedStream is our contractor there. The other big one is the OB hospitalist group, which provides some of the coverage for our birthing center. we're always, or, under my leadership, we are getting to the point where we're consistently evaluating, hey, does it make sense to have our own group or to continue to go with contractors? I think in some cases we'd be open to reestablishing our own group, but that's a big bet. But so those are the other two major contracts that we have that are similar to radiology. Meg, have I left anything out there?
Not for the hospital.
Okay, and I guess my last follow-up final question then is, does free and reduced care apply to those services? And do the rate caps similarly, are they not under the Gifford rate cap as well?
My understanding is that those two are subject to Gifford's financial assistance policies. They get billed as if they are our staff. And so they would be subject to the same financial aid policies and charity care that I talked about earlier today.
Okay. All right. Thank you. That's all I had. Guess it's over to you, Dave. Or maybe
Sorry,
Stephen Foster.
one clarification. Jess Holmes had two questions there. One was the free care bad debt, and then the other was the whether it's subject to the rate cap, your rate cap.
I'm trying to answer this as directly as I can. For anesthesia and OB hospitalist group, it is billed as if it's 100% Gifford service, and so it'd be subject to all the limitations that we have.
Great.
So
thank you, including our rate caps.
Yes, including your rate caps.
Great. Yep. Thanks. All right, Dr. Merman.
Great. Thanks. I guess I was going to start with a quick comment about something you had mentioned earlier, that your cafeteria is excellent. So I've known that you have an amazing Thai restaurant in Randolph that I've never made it to, apparently world class, but I've never gone to your cafeteria. So maybe
we can confirm that SOP is quite good. It probably edges out our cafeteria, maybe. So
yeah, well, I don't have to make a reservation at your cafeteria probably, but regarding one more thing with the Rutland radiology group, I thought you said that they're not, and maybe this was just covered, but I missed it. They're not subject to the provider tax. Is the Rutland Radiology Group not part of Rutland Regional Medical Center, or is it an independent staffing?
It's independent, and I want to be respectful of those guys in RRMC. My understanding is that they're a fully independent group that historically has served one customer, which has been Rutland Regional Medical Center, and they're located in part inside the medical center. And so they're not part of the hospital, and their revenue is not, to my understanding, covered by, they're not a taxed class under the provider tax.
At a hearing earlier this week,
I apologize.
No, go ahead.
We mentioned Rutland Regional because the idea of partnering with the radiology group in Rutland came out of the regionalization discussions that we're having with other Vermont hospitals, including Rutland Regional, and it requires tying technology and things into their site at RRMC. And so they really opened the door, as Judy and I had a very candid conversation about, all right, what could we do? If the bias right now is to do something, what could Rutland and Gifford potentially do together? And among several options, radiology emerged first.
Another CEO mentioned in a hearing, critical access hospital CEO, if he were to lower expenses, he would lower his Medicare cost-based payments. Given that you're a critical access hospital, are you disincentivized to reduce costs because it could reduce your payments?
I would answer that yes, but I mean, we've lived that over the last year and a half with this Medicare cost report issue, and I would say do it anyways. I mean, you need to be more efficient, and it'll help you pick up contribution on Medicaid and commercial, and it's just the right thing to do. And so there are some disincentives, but without having a spreadsheet in front of me, I think the financial benefits would likely outweigh it if you took your whole book of business. They don't know it, but I'm staring right at the finance people on this call when I say that. But the federal rules create all sorts of perverse incentives, and the cost settlement one creates a penalty in a way for being more efficient over time.
Okay. I wanted to sort of just discuss briefly in sort of the concept of pursuing affordability and sustainability. I really think it's important to understand the importance of improving operational efficiency and access, and the role of provider productivity in that improvement. we've heard several different strategies on how to communicate this, on how to implement improvements in provider productivity. And I just want to call out the nuance that you all have used in the hearing today. It sounds like you're approaching provider productivity in a system-based way, in a mission-oriented way, in a way that individually tailors the productivity to the specific situation or service, and not sort of an across-the-board thing. And so I just want to call that out and say, I think as a provider and as understanding sort of the nuance and complexity within this topic, I just think that I appreciate the approach that you're taking, although I still think probably all of us in the state are going to have to figure out how to do more with less, as has been mentioned many times in all of these hearings. So you also mentioned sort of the impact on culture, and I wanted to sort of extend that to a bit, is that culture, is a big, and not saying that a non-productive culture is a culture of safety, but that all of the culture impacts safety, impacts patient effectiveness and care treatment. So I just want to sort of call that out, and I appreciate the tone and the nuance that you've taken in this.
Thank you.
You said you're doing a strategic pricing review, and what are the goals of your strategic pricing review?
I mean, to my mind, it's the following. Pricing seems to be all over the board. Frankly, people here, particularly with a new senior leadership team, we very soon, when our CMO returns to full-time emergency department practice here at Gifford, we'll only have one senior leader who's been here for longer than 2 years. So we just haven't done the work to understand our prices, which has felt acutely uncomfortable during the hearings that the Green Mountain Care Boards had on Medicare pricing issues, right? It's hard to show up and say, we agree with your point, but we're struggling to figure out how to help. So we need to do that work to figure out where we are. So we don't know where we are. We can't pick a lane where to go. What I want out of that, based on everything I've heard from this board, is our prices converted to a percentage of Medicare. So I know where we are within the great discussion about where prices should eventually be. And from there, I feel like we'll have a list of outliers, both up and down, because we've got some feedback from insurers that, hey, some of your prices are curiously high and some of your prices are curiously low. And from there, I imagine having a discussion with both payers and with all of you as regulators to say, hey, how do we walk these prices into a tighter band over time? But absent information, I can't do any of that, right? And then I think having that information will also arm us in any future discussion with a commercial payer or public payer about a global budget, which we're still interested in, but the details clearly matter. And so I really view a report from a consultant about our current prices as the gate to open to climb up the ladder of, hey, we have ideas that we'd like to work with payers in the state and the board on about how things should be priced and packaged up in the future.
Have you picked a consultant for the work?
We've been in discussion with Helms and Company, but as you know, Board Member Merman, our former CFO, we've just had a CFO departure and a CFO onboarding. And so that's something that's going to have to be picked up by the new CFO. I'm not saying that in a, oh boy, we're going to have to wait 6 more months sort of way. There's not time for that. That work needs to be accelerated. But that is our customary partner on payer agreements and prices. And so they know us a little bit, and that's where we're going first. I've also talked to some of my colleagues that are using Kaufman Hall for that work. And so we haven't made a decision yet, but that those would be 2 of the more likely partners in my view.
You previously quite publicly cited concerns about the Oliver Wyman report. I think one of the big areas was around the volume data that I believe was supplied by VAWS, and said, quote, Gifford's leadership no longer considers this report a credible foundation for future healthcare planning. But now you referred to it in your opening remarks as a difficult but necessary gift. So what's been the process of changing your view on this report, which I think has been changed? I don't think those 2 are entirely consistent.
Well, the way I would square that circle, Board Member Merman, is that Gifford, perhaps like other Vermont healthcare organizations, needed to recognize that itself and the system needed to change. Whether you agreed with the Oliver Wyman report or whether you agree with the data in that report, you could not look at our financial performance our access, or any of the other piece of our business and say, this is okay and this is sustainable. And so that forced us to have that reckoning. And so I think I'm at the point with that report where whatever the numbers are in there, it was the shock to the system that made us as a group, and I think our board of directors would agree with this, say, this is not okay, this ship needs to turn. And so it's served as the impetus, whatever the particulars of the data were. I would also note, Oliver Wyman came out just about my first day on the job. That's a funny way to meet people. And so, the team's hurting, you're trying to rally the team. But I 100% believe with the benefit of almost 2 years, when you're moving through life like a rower, moving forward and looking backwards, something needed to break the status quo bias in healthcare around here. And that report, at least for Gifford, broke the deep status quo bias that we had and forced us to take action.
Thanks for that, sharing those thoughts on that. One of the other areas was on, you mentioned in some of your quotes, was on recruitment and retention challenges because of the report, but it also kind of sounds like now Gifford's been fairly successful in the recruitment and retention. How has that played out for you?
Yeah, that is true. And one of the biggest issues was we had lost our radiologist and had to very quickly get a third party. And so the Rutland, there's a straight line between Oliver Wyman and our partnership with Rutland on that. I think recruitment is going better. I think that's a result of 3 things. One, we elevated and expanded our HR department. It was, when I got here, it was not at the senior leadership table. It was a director position. And just to me, it was kind of like one of the root causes of dysfunction was not having enough resources in human resources. And so people would apply for jobs and it would take a really long time for people to get through the process. If a clinician would get in touch with us today, there's a pretty good chance someone's going to reach out to them today or tomorrow and say, hey, Gifford's awesome, you should talk to us. And so I just think, like everything else at Gifford, there's been leadership and efficiency introduced that has helped break us out of our little slump. 2, being more successful, people tell their friends. 2 years ago, I'm not sure what people were supposed to tell their friends about Gifford. Now it's, hey, like, it's different. They're really transparent. They talk to us. They're fighting for rural healthcare. You haven't given up the birthing center, which I think, though there are some financial challenges there, that buys us some credibility that we're really committed to rural health. And then the weather outside of Gifford is not necessarily better than the weather inside Gifford. I think UVM and Dartmouth, candidly, are perhaps less attractive to our workforce because UVM and Dartmouth are doing their own hard work to improve their system and are making personnel changes that perhaps make leaving less desirable for folks. So I think combination of HR leadership and efficiency, better management and transparency, and just a rugged overall environment have led to us being able to more effectively recruit and retain people.
I do appreciate the emphasis that you had in the presentation about trying to improve local oncology care and partnering with UVM. But I think I'm also aware of sort of this complex financial incentive system in Vermont right now with oncology infusion medications, where a critical access hospital like yourself is not subject to the limitations of Act 55. You also seem to be very focused on supporting this, the ideas of affordability and sustainability for the state and for Vermonters. So how are you balancing this complexity of trying to increase access to oncology care, which would likely bring high priced infusions, with sort of the notion of trying to improve affordability for Vermonters?
Yeah, that's a great question. And I will share how I've talked about it with my leadership team. My ongoing view is that if, say, we were start to produce a large positive margin, right, which hasn't been the case for many years. Joe Wooden had a fabulous run here, but it's been tough sledding for a while. But if we, between, say, infusions or independent surgeons being in our OR, or for some other reason started to put together large margins, we would have to pair that with what we learn in the strategic pricing analysis and the subsidies we give to other parts of the care continuum, like the nursing home, and come to you and say, well, how do you want us to reconcile this, right? And you have your own rate caps and enforcement mechanisms and say, all right, like you're not suddenly going to allow a critical access hospital to take one service that is capped somewhere else and generate a huge margin on it. like how much of that goes to affordability, how much of that goes to investment, how much of that should go to another piece of the care system. I think it's part of the reason why we're trying to have a discussion about our whole enterprise with you, because we think in the future, if we're successful, we're going to have conversations like that. So I just think, the key to it though is understanding your pricing. So then you have a lever or knob you can turn. If one thing goes up, you can say, okay, what thing needs to come down? So you're at a place of moderation between the prices that Vermonters pay and the investments that are needed within the system.
So I think from one of the things you said there, if I was to pull it out, is that when you talk about if you were to have in excess of revenue growth beyond what would be expected, that the enforcement process would be a reasonable way to adjust the prices such that the revenue growth or margin growth was in line with other affordability goals.
I would qualify that in just one way. The enforcement process is one of potential several ways that you could agree on where prices should be. I would like to think that between the Green Mountain Care Board, the hospitals, and our flagship commercial payer, that we could do a better job of getting towards the prices that are sustainable without an enforcement action. But an enforcement action would be one way that you could potentially do that. But I think for the most part, I expect one of my biases in that answer is that we're going to continue to have a robust discussion about prices for many years to come. And that Gifford needs to be a player in that. And if you saw a spike in one thing, you would ask a lot of questions about whether that's appropriate and where does that make sense within the whole rest of the pricing scheme and the rest of the system overall.
I appreciate that long-term view of this as well. So, all right, on a critical access cost sharing issue, when I'm looking at your fee-for-service revenue workbooks, does that include the cost-sharing payments from, say, commercial Medigap plans or Medicaid as a secondary payer or self-pay, or are those reported separately in the commercial, the Medicaid, and the self-pay areas of the revenue sheets?
So I don't know the answer to that question. I'm going to defer to Bill King to see if he does.
Yeah, thank you for the question. They would be reported separately. We record revenue from the payer that we receive it from and the payments. So if it's been shifted from commercial to another payer, that's where it would be recorded.
Okay, I might just ask and follow up that you double check that, because it's very different than some of the other hospitals. And so then I want to make sure that we're sort of seeing apples to apples, that if a Medigap payment comes in for a Medicare patient revenue, that it lives in, that it would be separated into commercial. But I'll follow up in a written question. Two more quick things on the way out. Oh, go ahead. Yep.
No, we're happy to follow up with you on that.
Great. There is one more 5-star hospital in Vermont. It's the White River Junction VA. So I just want to say that they are not regulated by the board, but they are a 5-star hospital. And two, Michael, I want to give you kudos, because I understand that while you did not give a single baseball analogy that I have heard so far today, which is atypical for you, but I heard you coached the Vermont state champion Cal Ripken team to victory recently. So I just want to give you props on that, and thank you.
You did. Two quick things. One, I will apologize to Brett and the team at the White River VA for our talking point. And two, thank you very much. To be in Vermont is to be involved in small community life. And Norwich's baseball state championship was an enormous amount of fun this year. So thank you for putting that on the record, Board Member Merman. So.
Great, thank you. A couple of questions on the Medicare cost sharing issue and the charge master. Who is responsible for making decisions as to how much and which services to increase in the charge master?
And I want to make sure I understand the question correctly. I would assume that'd be myself and the CFO, aided by the information we get from consultants. Perhaps I'm not understanding it, but that'd be my impression.
Yeah, what I'm getting at is each year the charge master is potentially increased or decreased in certain service line areas. And I'm trying to understand whose job it is to review the charge master and determine which services go up or down.
I only have 1 year of history, and that has been the CFO here. I would be involved in any strategic pricing analysis. That's the only thing that I would add.
And what documentation exists as to historical decisions relating to increasing service line charges in the charge master?
I would have to look into that. I'm not aware of what historical documentation is related to decisions regarding the charge master.
Right. Can you describe the process for determining whether or not a service line increase should be increased in the charge master?
My understanding as related to me by our former CFO is that whatever the rate increase granted by the Green Mountain Care Board is applied across the board. I have not checked that myself, but that's my understanding of past practice.
Okay. And you alluded to consultants. What's the role of consultants in determining charge master changes?
My understanding is that consultants historically have helped Gifford Healthcare negotiate payment arrangement with payers, though my understanding is that our arrangement with payers are quite simple. It's usually a % of charge. I reference consultants mostly in that Gifford Healthcare, perhaps like others, needs analytic help to study its pricing structure and what options might be best for the future. We do not presently have the analytic capacity in-house to get through that analysis in a timely way.
Is there any evaluation of the cost basis for a service line in determining whether or not that service line should receive an increase in the charge master?
I'm not aware of any of that work other than the routine work done within the Medicare cost settlement filing. I'd invite Bill or others, Bill to jump in if he has additional information on that.
Michael, I do not have any additional information on that.
Okay, thank you for that response. And can you expand on that a little bit? So the question was, what kind of analysis or work is done relating to evaluating the cost basis of a service line in connection with determining whether or not to increase the charge master?
During my tenure at Gifford, I'm not aware of any of our efficiency or cost work affecting the way in which we structure our charge master. After last year's budget order from the Green Mountain Care Board, my understanding was that we applied that rate increase across the board. I'm at a disadvantage with Cheyenne having left the organization on July 24th and trying to answer the question.
Okay. Are you aware of any historical review of the cost basis for service lines in determining whether or not to increase the charge master?
I'm not aware of any.
One of the other hospitals that has come before the board described an issue where with some of their commercial negotiations, the insurers balked at providing an increase to professional services, and thus to achieve the rate that the care board had approved, the hospital applied additional rate to either inpatient or outpatient services. Do you know if that's been a strategy at Gifford or an issue at Gifford, I should say?
Mr. Chairman, you broke up there for me for 1 second, so I'd kindly ask you to repeat the question.
Sorry. And if this doesn't work, try again. Let me know. But one hospital described a process where they had an issue with an insurer not providing increases on professional services, and thus they took some of the rate increase and applied it elsewhere to effectuate the overall change that the care board had approved. My question is whether or not that has been an issue or something that's happened at Gifford.
That has not happened. I'm not aware of that happening during my time here. My understanding is we just did an across the board rate, but we haven't had that type of issue with an insurer or taken that type of action.
Okay. And I believe I know this from your prior testimony, but do you have an evaluation of services that are priced at more than 500% of Medicare at this point?
I've been shown data from Blue Cross Blue Shield several months back, but we do not have our own comprehensive review of services above a Medicare threshold.
Okay. Can you send us that information as to Blue Cross Blue Shield? And if it's something that needs confidentiality, we can work through that process with board staff.
Yes, I will just check to see whether I was given that information or was just shown to me over a screen. I will has been part of our discussions with Blue Cross Blue Shield, but I have to check to see whether I actually received a document or was just shown it.
Okay.
We're happy to share with you whatever we have.
Yeah, let me know. And if you don't actually possess it, we'll get it from Blue Cross.
Yeah, that's fine with us.
Okay. I think that's all I had. Thank you all very much for your testimony and providing a lot of background on the good work that you're engaged in, and we appreciate you coming today. I'll turn to the healthcare advocate for any questions or comments they have.
Mr. Chairman, prior to going to the healthcare advocate, I just want to correct the record. We bill for the OB hospitalist group. I believe MedStream, our anesthesia provider, bills their own professional fees. I believe I misspoke earlier in the presentation.
Great, I appreciate that. Thank you. Okay, healthcare advocate.
Yeah, good morning. Looks like my camera is disabled for now, but just in interest of time, I'll just go ahead. Thanks, board chair members, and Gifford for this is a really thoughtful hearing. Appreciate the responses. Just two questions. In your narrative, you wrote that the New England Collaborative Health Network staff report $9 million in collective cost avoidance and savings, of which there's my camera. Morning. Of which 890,000 is attributable to Gifford, and you said you guys are working to validate that. Could you just talk about that validation process and also identify who the New England Collaborative Health Network staff are?
So the New England Collaborative Health Network staff that we work most directly with is David Turner. And so, he serves as the director of the collaborative. We get a savings report from them. It was 890,000 at the time of our budget submission. You'll see in our slides today, we pegged that at 1 million based on the update I received in the last week from the collaborative. They have to break it out for us by service line or by initiative, group purchasing, insurance, et cetera. And by validation, it just means that savings estimate has to go to our facilities people and just like, hey, are we actually getting the value that our per group purchasing and materials management people rather, and just try to can you quantify the savings that we have? By and large, we rely on them to provide that estimate. But we try to talk at the management level to the people doing the work on the ground to make sure that is actually happening. And so I was just trying to convey that these are estimates that we get from the collaborative.
Got it. Okay. Member Merman asked a little bit about the Oliver Wyman report. A version of another question in that line is one of the worst case scenarios of that report was needing to transfer OB services. I wonder if you could talk about that service line particularly and what future you see for it.
So one of the things I learned in 20 years of government service, whether it be Massachusetts, Wisconsin, California, or Vermont, particularly watching good leaders, is you got to figure out what hill you're willing to die on. And I just happen to believe, and I think our team and our board supports this, that we need to be giving moms and families a choice where they have babies. And so we're really committed to trying to do what we need to do financially to make sure that service line stays open while simultaneously advocating to the state Medicaid program and policymakers that reimbursement needs to go up. Our number of births have climbed over the last couple of years in very small increments. And so we haven't seen a decline, which is good, but we need to put some thought into how to grow it over time. Our posture is to try to run a more efficient hospital so we can hold on to this service while fighting for reimbursement increases. And then per the Oliver Wyman study, if there is an opportunity for regionalization or centers of excellence for women's health, we want to be in that conversation. I think what potentially hurt the most at the time of the Oliver Wyman report, and I have to say again, that's right when I started, was the sense of not being in the game. And then Gifford had a moment of looking in the mirror and say, well, there's a reason why we're not in the game, financially, productivity, utilization-wise. And so the last 2 years have been in service of getting back into the game so we can be part of these discussions. And one of the areas of opportunity we see is to be a regional leader in our birthing center in maternal and women's health.
Thank you. Appreciate it. Those are my questions.
Public comment via raise the hand. Douglas Sutton. Mr. Sutton, you may be muted, but you're called on and the floor is yours.
Is the audio better?
Yeah, you just started coming through.
Okay, thank you. Terribly sorry for the technical glitch. I've been listening to all of the hearings the past 10 days, and I do hear a common theme about the shared services and the different collaboratives. My question, a little blended, is for the Gifford leadership team. Earlier in your presentation, you had mentioned that you are working with some collaboratives and doing the shared services. Could you give us a generalized, at least response? I know it can be very, very detailed, but give us an idea what barriers, if any, are you experiencing that are preventing you to moving a bit more aggressively or where you would like to be? And the second part of the blended question is where possible, the influence of the Green Mountain Care Board may be of assistance. Thanks for your time.
I think that's a valid question and a good point. Mr. Costa, public comment, you don't have to answer, but I'll give you the opportunity because I did think that was a prudent question.
Yeah, I think the primary obstacles to not moving faster on shared services, at least for Gifford, is one, operational capacity. We still have a lot of cleanup work to do. Two, getting into place of a positive margin. So you're dealing with that in a position of strength. And then three, you can only dance with people that want to dance with you, right? Like everybody's going to have to take some risk and accept some change if we're going to share services. I'm hopeful the New England Collaborative Health Network and others can help us make that transition. We look at the Green Mountain Care Board, Mr. Sutton, as a partner, not an adversary, not the policeman, though they do have an oversight and accountability function. And I think the more certainty they can give healthcare organizations about what the future looks like, the better we can plan. And however you look at the future, you're going to need to get the benefits of scale, as we put in our presentation. And so if you give us certainty, we can more quickly get to scale. Hopefully that is an answer to your very good questions.
Excellent. Good job. Keep putting. Does pay off.
Great.
Thank you.
Thank you, Mr. Sutton. Any other questions or comments via raise the hand? All right, great. Gifford team, thank you all very, very much for your budget presentation, and we'll take a recess. I'm going to push back the next meeting to 12:45 since we had a little bit of a later start today. So the Scutney hearing will start at 12:45. Thank you, everyone. And we'll take our recess, and the Gifford team have a good afternoon. Thank you.
Thank you very much. Appreciate it.
Thanks.